Dear Vito, ladies and gentlemen, dear colleagues, it's an honor for me to talk about characterization of malignant liver tumors using contrast-enhanced ultrasound. So my agenda at this stage would be to refer to the EFSOM guidelines, describe a little bit about techniques. Detection of malignant focal liver lesions will be characterization, and I will explain why. The differentiation and characterization of such malignant liver tumors, which will be hypoenhancing in the portal venous and sinusoidal phase, can be differentiated from benign entities, because benign entities will be iso or hyperenhancing. We will show examples. I will come to a conclusion. 2004, EFSOM introduced guidelines on CUs about the liver only. In 2012, there was a combined initiative of EFSOM and WFUMP publishing the third update of CU's liver guidelines. The data I'm representing and the literature referred means such EFSOM, WFUMP guidelines published in European Journal of Ultrasound and in Ultrasound, Medicine and Biology as well. Contrast-enhanced ultrasound has been also standardized. That means we have a quantitative way to express the contrast-enhancing features by analyzing time intensity curves, and this has been also summarized in guidelines and recommendations. To give you an example, that hyperenhancement during the portal venous phase can be delineated by orange color, as shown here. Whereas hyperenhancement in the arterial phase, you can see my arrow, is shown here. And during the portal venous phase, we see here hypoenhancement. This means such lesions have less portal vein branches, less enhancement compared to the surrounding liver parenchyma, and they have to be, from a clinical impact, histologically proven. There could be malignant lesion destroying portal vein branches. There could be benign lesions with less portal veins, but still the conclusion is the same. They have to be under oncological criteria if age and comorbidity are not against biopsy. They have to be proven by biopsy and histology. I'm going to show a normal enhancing feature. You can nicely depict in that lesion a central artery and enhancement pattern. But we are missing one information, and this information is time. With parametric ultrasound, you can also delineate the early yellow, the later green, and finally the blue enhancement pattern, and therefore we can not only display the enhancement pattern but also the time line behind, as shown in such images. If you are interested about that, you are cordially invited to read that supplement of European Journal of Ultrasound. So first I introduced techniques, and right now we will talk about data. The DEGUM, Deutsche Gesellschaft für Ultraschall in der Medizin, multi-center trial, has proven in more than 1,000 patients a high sensitivity, high specificity, and very good positive and negative predictive values with a finally diagnostic accuracy of 90%. Many other studies have proven that differentiation of benign and malignant lesions is possible. The clinical background. Whenever we use contrast-enhanced ultrasound, we have to use it with the knowledge of clinical prior imaging features and laboratory data. We have to include all that information into the interpretation under oncological principles. Up to now, there have been only very few positive findings which show hypoenhancement in the portal venous and late phase, mainly from abscesses, which are not malignant, necrosis, old fibrous focal nodular hyperplasia, but also hepatocellular adenoma, cholangiocellular adenoma, and sarcoidosis. Pseudo-inflammatory tumors might show hypoenhancement, but all lesions in the patient with eventually a malignant history have to be proven by biopsy, and therefore hypoenhancement in the portal venous sinusoidal late phase needs to be proven by biopsy and histological examination. Coming back, we have the two vessels from the liver, hepatic arteries and portal vein branches and sinusoids, the liver-specific vascularity. Have a look to the left. You can nicely depict here the central artery and the portal vein on the right. And you can see that this lesion is arterial enhancing, and this lesion is enhancing in the portal venous phase, comparing the vessels with the respective focal liver lesion. CUS improves detection during enhancement of the liver-specific vascularity. This is normal way, but sometimes you can also depict lesions only or mainly in the arterial phase. Later on, Professor Piscaglia will show us this kind of characterization in the arterial phase, which is mainly true in liver cirrhosis. Coming back to the value, CUS has the same value as magnetic resonance imaging for differentiation of benign and malignant lesion according to the evidence of literature, and CUS and MRI are better than computed tomography. Here you can see the enhancement pattern of a focal liver lesion, and you can see some stealing effect right on here. And this patient was referred for operation. CT and MRI didn't show any additional lesion. But as you can see here, there have been tiny spots in the surrounding liver parenchyma which showed hypoenhancement in the portal venous and late phase. And that means that such lesion can not only be detected, and I mentioned beforehand, detection of hypoenhancing lesion in the late phase means liver foreign tissue and quite often malignant infiltration. Here's a case of a lesion which can only be delineated during the arterial phase. It was a metastasis of GIST. This is a rare occasion. Most commonly, we detect malignant infiltration of the liver during the portal venous and late phase. Therefore, malignant lesions are hypoenhancing in comparison to the surrounding liver parenchyma in the portal venous, sinusoidal, and late phase. Hepatic artery is displayed right on here. Enhancing portal vein is not enhancing at all. A few seconds later, you can see parenchyma is enhancing as well, and there's a lesion next to hepatic artery and portal and the portal vein branch. A few seconds later, you can see that the portal vein branch is enhancing as well. And right now, there's a change from hyperenhancement into hyperenhancement into hypoenhancement during 3 to 5 seconds. In the late phase, the lesion is hypoenhancing. And this makes a difference to CT and MRI. The change from hyperenhancing here, portal vein is not enhancing, to hypoenhancement is about 3-4 seconds. I will show you in an image video. Here, hyperenhancement, portal vein is not enhancing, arrow on the left side. Right now, you see portal vein enhancement, and here, hypoenhancement of the lesion. So, it's within a very short period of time that you can see hyperenhancement due to arterial blood supply and the hypoenhancement due to portal vein blood supply. On the right side, I will show you hyperenhancement was orange, I mentioned before, dynamic vascular pattern. Right now, portal vein starts to enhance, and we can see quite nicely the hypoenhancing blue lesion, and this gives us a more distinctive feature that we can delineate: hyperenhancement, isoenhancement orange, and hypoenhancement blue. The malignancies we have to take care are HCC and hepatocellular carcinoma and cholangiocellular carcinoma, lymphoma, sarcoma, and other rare entities. About HCC, CCC, in liver cirrhosis, Professor Piscaglia will tell us more. I will go into a few examples. Just to conclude, we have been talking about two techniques which gives us additional information, which is parametric ultrasound, the timeline, dynamic vascular pattern, the orange hyperenhancement, and the hypoenhancement during the portal venous phase. And we have been talking about the features of malignant lesions which are hypoenhancing in the portal venous and late phase. According to oncological principles, in a patient with possible malignancy, we have to perform biopsy and prove the lesion by histology. A lesion in the liver, shown here, arterial enhancement, rim enhancement, hyperenhancement during the arterial phase, and a few seconds later, hypoenhancement. In this case, the biopsy and histology will prove metastasis, and we have to judge according to oncological principles if that patient will be treated by transplantation, surgery, local ablative features, or chemotherapy and additional therapeutic options. Prerequisite for such an examination means that there should be no bubble destruction in the near field, and that we have to have enough depth penetration, which can be improved by the correct depth penetration, by foci, and the lowest mechanical index possible with still enough depth penetration. If you are interested about avoiding such factors, I put in here some recommended reading. The interaction of mechanical index and bubble destruction is shown here. The higher the mechanical index, bubble destruction, you will increase the contrast dosage, there will be shadowing, you will increase the mechanical index, and this is a circle of disaster we have to avoid by a low mechanical index. Pitfalls. This is a giant hemangioma, a large hemangioma. You can see nicely the hyperenhancement in the surrounding tissue and hypoenhancement during all phase. This does not mean malignancy because the vascularized features are hyperenhancing during all phases. Sometimes 3D might be helpful for further information to show the whole process under different perspectives. But be aware that if you can see hyperenhancement in the arterial phase as shown here, and in the portal vein phase, later phase, you will find no more nodule, they are hypoenhancing, then we have to be aware that this might be a malignant lesion. Shown here, hyperenhancement like hemangioma, but the same area is hypoenhancing 2 minutes later. This could be sarcoma, or in this case, histologically proven hemangioendothelioma. The story of hepatocellular adenoma is very important for the differential diagnosis of malignant liver lesion. Just to repeat, hypoenhancement in the portal venous sinusoidal late phase means suspicion of malignant infiltration. But we have also benign lesions which might show hypoenhancement in the late phase because they have no or less liver-specific vascularity portal vein branches. We talk about hepatocellular adenoma. They might be hyperechoic in the beta-catenin activated HCA. They might have malignant transformation, but well published, not within the lesion, but within the surrounding liver parenchyma, a multiloculated HCC developed. HCA might be hypoechoic or most often isoechoic. You can even not delineate via B-mode echogenicity, which is the same for CT and MRI. You cannot even detect such small lesions. They seem to be correlated, the hyperechoic with the beta-catenin activated, the hypoechoic in fatty liver with HNF1 alpha inactivated, and the isoechoic with some sort of abortive storage disease. Hyperechoic, hyperenhancing lesion shown here in the arterial phase, hypoenhancement a few seconds thereafter. This means suspicion or suspected malignant infiltration, and in this case hepatocellular adenoma was proven in a patient with leukemia. After transplantation, you can see the lesion was much smaller beforehand. We have to learn that the size, the growth pattern of hepatocellular adenoma might behave like malignant lesions. And malignant transformation is one of the big issues in hepatocellular adenoma. There's one exception. In former times, the telangiectatic inflammatory varieties have been summarized as focal nodular hyperplasia. And you can see such a huge lesion here. Biopsy and histological examination revealed FNH patterns and HCA patterns, so mixed patterns between focal nodular hyperplasia and hepatocellular adenoma. In this case, hyperenhancement was seen during all phases. To summarize, hepatocellular adenoma have different entities. All of them, except the teleangiectatic variety, has no portal vein branches, and therefore they are hypoenhancing, like malignant lesions. In all hypoenhancing lesions, we go for biopsy to prove histology. This is the story of HCA. Let us talk about malignant transformation. To our experience, most of malignant transformation is at the edge of HCA or at different locations. The malignant transformation is a big issue still not solved. The entity of cholangiocellular adenoma, this is arterial hyperenhancing lesion right on here. And you can see in the arterial phase, hyperenhancement, in the portal venous phase, hypoenhancement. Because also, not only hepatocellular adenoma, but also cholangiocellular adenoma show hypoenhancement due to lack of portal vein branches. The enhancement pattern to determine the therapeutic response is also a big issue, and I mentioned dynamic contrast enhanced ultrasound techniques to analyze time intensity curves. Here you can see a histologically proven metastasis of a GIST tumor, gastrointestinal stroma tumor, hyperenhancing in the arterial phase. Let's look. This was, I cannot see the date, but it was 3 months later that the lesion could be displayed here. And you see during arterial enhancement, during the arterial phase, no enhancement at all. Imatinib drug treatment was effective, and all that tumor vascularity was gone. But the lesion, from the size, if we talk about RECIST criteria, would have been still the same. But we learn that quantitative ultrasound, dynamic contrast enhanced ultrasound, will help us to differentiate between the different levels of arterial enhancement. I hope that I brought some light in the characterization of focal liver lesions. And I'd like to conclude that all that knowledge has been summarized and published in the EFSOM guidelines, the European Federation of Societies in Ultrasound and Medicine Biology. We have been discussed that there are techniques at horizon which give us quantitative measurements, semi-quantitative support to analyze more objectively. We learned whenever there is a hypoenhancement of an arterial hyperenhancing lesion, an hypoenhancing lesion in the portal venous phase, that this improves detection of lesion, but also means that it's liver foreign tissue and highly suspective for malignant focal liver lesions. If you look for the clinical background, age, comorbidity, in such a patient, biopsy and histological provenness of the focal liver lesion has to be done. I have shown examples of borderline lesions like hepatocellular adenoma, cholangiocellular adenoma, different others have to be accounted as well. All patients with HCC and CCC in liver cirrhosis will be topic of the last talk, and benign liver lesions will be the talk of Professor Ortelge Gilja. So I would like to say thank you very much for your attention, and I'm looking very much forward for a good discussion. Thank you.
Thank you. Thank you, Christoph, for your very nice comprehensive overview on the malignant lesion as visualized at CUS. Now we have some time for some questions, and there are some from Alexei Borkov. He asked to you, which are the peculiarities of metastasis after chemotherapy that you can describe at CUS? This is first questions.
Yes, so this is a very important question. To take this answer, I would need 30 more minutes, but finally we can discuss a few cases. If we look for colorectal carcinoma patients, sometimes metastasis go away totally. So the best what could happen is the option that there is no more detection of metastasis in the arterial, portal venous and late phase, but also using B mode, CT and MRI. The best case. Think at the edge. In the worst case, there will be progress of metastasis during chemotherapy using the size of the lesion to determine the size of the lesion, or to determine the vascularity of the lesion using contrast-enhanced ultrasound. And we will learn more and more for some tumors like gastrointestinal stroma tumors and renal cell carcinoma that they might not change in size. They might even enlarge in size, but they are well treated using imatinib in this case. What happened? The vascularity is destroyed. We have necrosis. There might be intratumoral bleeding, and even the lesion might increase in size, but you see no more vascularity within the tumor. So the behavior of metastasis under treatment is not anymore only to determine the size, but also the vascularity enhancement pattern. We have to be aware that we have to have the knowledge of the treatment using chemotherapy or using anti-neogenic medication like imatinib, which is yielded against vascularity.
I totally agree with you, Christoph. Another question also, again from Dr. Borsukov. He asked you if you change the dose of contrast agent according to the weight of the patient. And he asked you, in a patient with 50 kilos of weight with metastasis, how much contrast agent you suggest to inject?
Yeah. Also a very good question. I love it. We have to standardize our protocols. So in our department, we use almost in all patients 2.4 ml for almost all patients. Why? Because we put it into scientific protocols, and we have to standardize such protocols. There are some manufacturers and some settings you might change to 1.2, but then we have created an additional variable. So if I might summarize, if you go for a scientific protocol, stay as stable with your dosage whenever possible. If you look for individual patients, you might be allowed, according which equipment you are using, to reduce the dosage. This is in accordance to the criteria of bubble destruction. Please be aware to have and to use the lowest mechanical index for a stable image. And please be aware to decrease the dosage whenever there is shadowing of the image, because you'd like to avoid not to have that depth penetration necessary to examine the whole liver. So I would say from 1 point, please try to be standardized as much as you can. 2.4 seems to be a good dosage for many circumstances. Individually, you might reduce.
Thanks so much. You were very clear. So last question, because we don't have so much time anymore, but I would like to ask you, in your daily practice, which is the role of time intensity curve? Do you use in any case, or your characterization is based on contrast enhanced pattern as you can visualize with your eyes?
In most circumstances, we do not use time intensity curve analysis, but we do believe that parametric imaging, dynamic contrast enhanced ultrasound, analyzing time intensity curves will be the future. So we will change from chemotherapy to drugs against vascularity, and we have to learn to quantify our changes of enhancement. And this can be done by ultrasound contrast agents at its best. Sonoview is a strict intravascular contrast agent. That means the same is not true for CT and MRI contrast agent. It stays in vascularity. Whenever there's a change of vessel density and vascularity in a neoplastic lesion under treatment, you can quantify using contrast enhanced ultrasound. This is not the past, a little bit of present, but it represents the future of our method.
Thank you, Christoph. As always, you are very clear, didactic and educative, and you provided us a good overview of what we can do by means of CUS in malignant liver lesions.